انا ممكن استخدمه مع الديفيوجن ويغنيني عن ان انا اعمل كونتراست لو حاله مثلا في مشكله في ان انا حقنها كونتراست، اكتفي بالكونفنشنال MRE مع الديفيوجن والاي في اي ام.
هو الفكره ان الاي في ام ده يعني هو ابروتش خالص، هو لسه مش لسه يعني حتى لسه البيبرز جديده جدا عليه، فلسه مش ما اتعملش حتى يعني انا لوت اوف كيسز. يعني احنا حتى وير ليميتد بالكيسز اللي معانا 30 كيسز بس which is not huge برضو. فيعني محتاج اكتر يتعمل عليه ريسيرشز تو بي شور ان هو ممكن يغني عن الكونتراست. بس هو نيو ابروتش، يعني اكتشفنا ان هو بيوري ان العين ده ان اكتيفيتي اكتر، ان هو كرونيستي predominantly، فايتس ا نيو ابروتش بس not used يعني
لسه قدام شويه هيبقى
in the future.
Okay, ماشي. Thank you Dr. And now the next speaker Dr. Michael Naguib, Pitfalls in liver imaging. اتفضل دكتور مايكل.
Good afternoon, dear professors and colleagues. It's my pleasure to be here to talk about pitfalls of liver imaging. Despite various sophisticated imaging techniques, there are numerous pitfalls in liver imaging. The liver is a tricky organ for radiologists. There are several pitfalls to be avoided during liver imaging. Two major topics will be discussed today: how to identify the main mimickers of liver cirrhosis and how to identify the main mimickers of liver tumors. First, with cirrhosis. Cirrhosis is pathologically defined as multiple regenerative nodules surrounded by fibrous tissue. There are various imaging criteria for diagnosis of cirrhosis, including nodular surface contour, morphological liver changes including atrophy of right lobe and segment 4, hypertrophy of left lobe and caudate lobe, increased fat at the porta hepatis, and expansion of the gallbladder fossa. Also, signs of portal hypertension are seen as splenomegaly and portocaval collaterals. However, other non-cirrhotic liver conditions can lead to some morphological changes which mimic cirrhosis, and the majority of them are of vascular origin, like number 1, portal vein obstruction. But in portal vein obstruction, the atrophy-hypertrophy complex is different, as the hypertrophy is mainly central, including segment 4 and caudate lobe, due to maintained portal inflow, while the atrophy is peripheral. Also, the nodularity of the hepatic surface is usually not present. Like in this case, we see here that there is complete obstruction of the right portal vein with atrophy of the right lobe due to portal vein obstruction. Imaging features also include direct visualization of portal vein obstruction with lack of enhancement, also increased enhancement of the obstructed liver, as the arterial phase enhanced images is highly suggestive of portal vein obstruction. Second, with Budd-Chiari syndrome. The key finding in Budd-Chiari syndrome is the atrophy-hypertrophy complex. The atrophy appear in the obstructed liver segments, while the hypertrophy is seen at the central liver segments, including segment 4 and caudate lobe, as the hepatic vein outflow is not altered. Like these fat-suppressed T2 weighted images, we see there is hypertrophy of segment 4 and caudate lobe, peripheral liver atrophy, and signs of portal hypertension in the form of splenomegaly and portocaval collaterals. The diagnosis is further supported by direct visualization of anomalies at the hepatic veins. In post-contrast images, the liver enhancement is heterogeneous with mottled appearance, with delayed enhancement at the periphery of the liver and around the hepatic veins. Third, with congenital hepatic fibrosis. Also, this entity are usually diagnosed during childhood, but it's not uncommon to first see them at the adult patient. The most common complication is portal hypertension, and the most common association is autosomal recessive polycystic kidney disease. Morphological changes are found in most of these patients, including atrophy of the right lobe, hypertrophy of the left lobe and caudate lobe, and this all mimic cirrhosis. However, here, segment 4 is normal size or enlarged. Like this case, in these axial contrast enhanced images, we see right lobe atrophy with hypertrophy of the segment 4 and caudate lobe. Also, signs of portal hypertension are seen. Besides these morphological changes in the liver, other associated anomalies as renal and biliary disorders are found here in congenital hepatic fibrosis, and not found in patients with cirrhosis. This is highly suggestive of diagnosis of congenital hepatic fibrosis. Fourth, with obliterative portal venopathy. Obliterative portal venopathy is characterized by portal tract abnormalities, including thrombosis, fibrosis, and sclerosis, and it's one of the disease which closely mimics cirrhosis, as the portal hypertension is a key finding. Presence of portal vein anomalies help to differentiate between both obliterative portal venopathy and cirrhosis. Presence of anomalies like complete or partial obstruction, stenosis, and mural calcification is usually found in obliterative portal venopathy. Also, the nodularity of the liver surface is rarely found. Fifth, with liver metastasis, also known as pseudocirrhosis. Also, this entity can develop in absence of chemotherapy, but it's commonly associated with chemotherapy. Its mechanism is due to tumor shrinkage and subsequent fibrosis. It first was described in patients with liver metastasis from breast cancer, but now are seen also in patients with esophageal, pancreatic, thyroid, and colorectal cancers. Imaging findings include segmental atrophy, various degree of liver contour abnormalities from limited retraction to diffuse nodularity, and portal hypertension in severe cases. Like this case, in this case, first image we see that there is a solitary liver metastasis. After several cycles of systemic chemotherapy and target therapy, the metastasis has regressed, but the surface showed nodular surface contour known as pseudocirrhosis. So the key to diagnosis is the clinical history and normal liver imaging results at prior examinations. It's important to be aware of this entity because in these patients, anti-cancer therapy should be modified and sometimes interrupted. 6, with acute liver failure. It's a very severe disease with a very high risk of spontaneous mortality. It's characterized by onset of hepatic encephalopathy in absence of pre-existing liver disease. So the clinical background, negative hepatitis B or C serology, and no history of alcohol abuse favors the diagnosis of acute liver failure, as unfortunately imaging features mimic cirrhosis. Portal hypertension can be seen in these patients, and ascites is the most common finding. Even more confusing that liver atrophy and liver surface nodularity is seen in up to 43% of these cases. Last, with post-therapeutic changes. After therapy, morphological changes can be developed, and it's very easy to recognize this entity based on the patient history, such as after major liver resection, hypertrophy of the remnant liver segments occur. Also, non-surgical liver-directed therapy, such as radioembolization, can result in marked atrophy of the treated part of the liver and hypertrophy of the rest of the liver. Like in this axial contrast enhanced CT image, first case, it's a case of cholangiocarcinoma, was further treated with radioembolization. It show tumor shrinkage and also the right lobe show atrophy. Second, with the main mimickers of liver tumors. The major mimicker of liver tumor is whether the tumor intrahepatic or extrahepatic, as extrahepatic tumors can mimic intrahepatic one, and the larger the tumor, the more difficult to identify its origin. As a general rule, it's definitely intrahepatic when a part of the liver parenchyma is located outside the tumor, and it's extrahepatic when the liver parenchyma is compressed and displaced. Like in this case, it's intrahepatic or extrahepatic. In first image, we see, in axial image, we see that there is a part of the liver outside the lesion. So it's intrahepatic. And the coronal image confirms the intrahepatic location. And as a note, there is no displacement of the right kidney. So this one is an intrahepatic tumor. However, this finding may be lacking, and in some situations, it's very difficult. So it's helpful to identify the site of the tumor center. If the center is outside the liver, the tumor is probably extrahepatic and vice versa. Also, the arterial blood supply is an important source of information. This is very much easier in hypervascular tumor than hypovascular tumor. Like in this case, in first image, we see that there is enhancing lesion in axial image, it's intrahepatic or extrahepatic, it looks confusing. But in second image, in coronal image, we see that the lesion is supplied by the hepatic artery. So it's confirmed it's intrahepatic location, and this was pedunculated focal nodular hyperplasia. Also, 3 main landmarks can help us in large tumors at the right upper quadrant, which are the IVC, the portal vein bifurcation, and the right kidney. Look to this case. In first image, we see that there is a cystic tumor. Is intrahepatic or extrahepatic? Look to the IVC, it's displaced anterior. The main portal bifurcation has rotated clockwise. And in second image, in coronal image, the right kidney has moved caudally. So it's extrahepatic, not intrahepatic. It's of retroperitoneal origin, and this was cystic pheochromocytoma. Also, the center of this lesion, its center on the IVC, it was leiomyosarcoma of the IVC. The major mimics of intrahepatic tumors are pseudotumors in a specific location, like the posterior part of segment 4, including fat-sparing or fecal steatosis, around the gallbladder fossa, around the falciform ligament related to anomalous venous drainage by inferior vein of Sabé, also enhancing pseudotumors. Not every enhancing lesion is HCC. There are enhancing pseudotumors. But in hepatic arterioportal shunts, but imaging features in shunts include that they are small, wedge-shaped, seen at the periphery of the liver. It appears only in arterial phase, and they return to normal during the portal venous and delayed phase. This is different from HCC. Also, there is no corresponding focal abnormal signal at unenhanced T1 and T2 weighted images. Second, enhancing pseudotumor as occur in chronic superior vena cava obstruction. It's usually associated with increased enhancement of the liver with this mimic hypervascular tumor, but it has characteristic location at the anterior segment of segment 4, and it's associated with development of collaterals. Third, intrahepatic splenosis. What's splenosis? Splenosis means autotransplantation of splenic tissue in the liver. This is developed after splenic injury, either due to trauma or due to surgery, and it shows increased enhancement during arterial phase. The key to diagnose intrahepatic splenosis include history, knowledge of splenic injury, the subcapsular location, mostly at the left loop, and the association with other hypervascular intraperitoneal lesions. Fourth, with focal confluent fibrosis. The key to diagnose is that it don't enhance during the arterial phase, but enhance later during the delayed phase. It has a specific site, as most cases occur at segment 4, segment 7, segment 8, and is usually associated with capsular retraction. Conclusion, the majority of the non-cirrhotic liver disease which mimic cirrhosis are of vascular origin. Careful analysis of the large intra and extrahepatic vessels is very helpful to assess whether a large tumor originates from within the liver or outside it. The most common pseudolesions at segment 4 are related to focal fat-sparing or focal steatosis, and most of these pitfalls can be avoided by the careful analysis of all imaging findings in relation to their fit with the clinical background of the patient. Thank you.
شكرا دكتور مايكل. واحنا اخر